All right, let's paint a picture of a patient. She's in her late 50s. She's not asking for bigger lips, but she sits down and tells you she just looks tired around her mouth, maybe a little sad, a little older than she feels. Now, you've done your baseline filler training, but if you treat her the way you treat a 30-year-old who wants more pout, you're going to make her look worse, and she won't even be able to tell you why. She'll just know she doesn't like it because her problem is not that her lip went flat. Her problem is that her lip has aged, and those are two very, very, very different problems. So each of those are going to require a different game plan. Here's what's actually happening underneath the vermilion of the lip. As a lip ages, the orbicularis oris, that muscle that rings the mouth, changes its shape. In a young lip, it sits in kind of a J curled up and forward posture. And that's what gives you that everted pouty edge. But as we age, that muscle flattens and rolls inward, more like an L shape laying down. At the same time, the bone underneath, what's happening to it? It's resorbing. The maxilla and the rim of the piriform aperture, they pull back. So the whole shelf the lip is sitting on, it's collapsing backwards. The cutaneous lip, that skin between the nose and the vermilion, that skin gets longer as a result. And that philtral columns, those little columns above the lip, and that cupid's bow, they tend to flatten out and they lose their light. And that DAO, the muscle that drags the corner of the mouth down, it gets relatively stronger. So the commissures turn down and you get that resting frown look. So what do? We put that all together. The lip didn't so much lose its volume as it lengthened, rolled under, dropped its corners, and lost the bone behind it. If that is the problem, what does pumping a syringe of volume into the body of the lip actually do? It takes a long, rolled under, downturned lip and makes it a long, rolled under, downturned, heavy lip. You didn't reverse aging. You added weight to a structure that's already sagging. That right there is how injectors make people look overdone instead of making them look younger and fuller. So here is the protocol, and the headline is this: release before you fill. You're in the right to add volume by first fixing what is pulling the lip down and in. Step one, release. What do I mean by that? Before any filler touches that lip, you treat the muscles. You do a lip flip, a few units of neuromodulator into the superficial orbicularis, oris, along that upper border. That lets that rolled under edge evert and show the vermilion she already has. Add a few units to the DAO on each side, and that stops that downward drag, that downward pull on the corners of the commissures, and they can come back up towards neutral. If her chin is dimpling and pulling the lower lip down, address the mentalis muscle too. Then you let that settle and you reassess. A huge amount of what you just did with that tox is going to address a lot of her concerns, and you haven't even added a single drop of filler yet. All right, so you've done that. Now what's step two? Now add structure. And the key word is structure, not volume. You're an architect restoring a building. You're not filling a balloon. You support the vermilion border and the white roll, where the vermilion border hits the skin, to bring back that crisp, light-catching edge. You rebuild the philtral columns with tiny, precise threads of filler to restore those ridges and define the shape of the cupid's bow. You can now support the modiolus just lateral to the commissure to help hold up the corner you just released with the tox, right? And you do all of it under hard volume sealing, because the moment you start chasing fullness, you're right back to making her look old again, right? So that's step two. Step three, address the skin. Those fine vertical lines around her mouth, the perioral rhytids, also known as smoker lips, they are a skin quality problem, not a volume problem. You do not fix a wrinkle by stuffing the lip behind it. That is where resurfacing and biostimulators come in, and we have courses on both of those that you can take. Here's the piece that makes you the professional in the room. You decide your target before you ever start the procedure. You have a plan before you're halfway through the procedure. The old textbook ideal is that golden ratio. A lower lip about 1.6 times the size of the upper lip. And that's still a great standard, especially for older patients. Interestingly, though, that preference has shifted in younger patients towards a more balanced one-to-one look. And it varies by ethnicity and gender. We've talked about that on some of our other courses. Especially with men. Men generally want a flatter, less everted lip, right? So for an aging patient, you are usually restoring more towards her own youthful proportion, not towards whatever's trending. So pick that target at the beginning before you start. Last thing I want to talk about in this module, and it might be the most valuable thing in it, you have to know when filler is the wrong tool entirely. There are 3 findings that should make you set the syringe down and talk about a surgical lip instead. 1, the cutaneous lip, that skin between the nose and the lip. It's gotten genuinely too long. How do you know it's too long? The skin above the lip should be roughly 1/2 the skin between the lip and the chin. So the distance between where the lips meet and the nose should be about 1/3 of the lower face, and where the lips meet to the chin should be about 2/3 of the lower face. When you start seeing that all drift down and it becomes more of a 50-50 ratio, it's going to be really, really hard to fix that with the tools in an Injectors toolbox. That's where you send them for a surgical consultation where they remove the upper skin right at the nose line and lift the lip up and pull that whole lower face up. Okay. Second, she shows little or no upper tooth at rest and barely any when she smiles. Right? That's a sign that the lip has drifted too far down. 3, she's already been volumized and the lip just keeps looking heavier and longer instead of younger and perky. When you see those things, no amount of filler fixes it. You cannot fill your way to a shorter upper lip, and every single syringe you add makes a long, heavy lip look longer and heavier. The move that earns most trust is to say, unfortunately, this is beyond what filler does well for you. Here's who I would send you to, and you find a good facial plastic surgeon in your area. That referral makes you look more like an expert, not less. So now let's bring it all together. Your late 50s patient, corners turned down, upper lip rolled under and thin, but she still has decent tooth show, right? Take a second. What is your first instrument and what is not? All right, if you reach for your neuromodulators before filler, if you decided to release the DAO and invert that lip, and only then planned a conservative bit of maybe filler border and column structure, you've got the sequence right. The mistake is leading with a volume dump. Release the muscles, reassess, 2 weeks, then restore. Under a volume ceiling. Just do some border work. You'd be surprised what just a little bit of border work in an older lip will do. All right, so it's been 4 months since you've treated a patient's lips. Everything was perfect, she loved them. Then she calls you and there's a tender swollen lump in her lip that showed up out of nowhere. Maybe it's red, maybe it's a little firm, maybe it's just a bump that doesn't hurt. And here's what most injectors do in that moment. You kind of panic a little, you default to the thing they know. They tell her to massage it, or then maybe they go grab the hyaluronidase, and start dissolving, and both of those could be exactly the right move and they could be exactly the wrong first move. And both can make her potentially worse. So let's build a protocol so you are never guessing on that call. The whole thing starts with one fork in the road, and getting it wrong is what can cause the damage. There are 2 completely different lumps that feel identical to a beginner. The first is the early non-inflammatory lump. It shows up in the first couple of weeks after filler, and it's just product that hasn't integrated yet, or maybe you place it a little bit unevenly. It's not red, it's not hot, it's not tender beyond the normal. That one you massage, or if it lingers, you dissolve, put a touch of little hyaluronidase in there. No drama. That you've learned that from your baseline training. The second lump that we're worried about, that's what this module is about. The delayed inflammatory nodule. It shows up weeks, months, sometimes a year or 2 later, long after everything's settled. It's tender, often red or warm. Sometimes it comes and goes. Sometimes one flares and another one fades. That is not an integrated product. It is an active inflammatory or infectious process, and you do not treat it like the 2-week lump. If you mash on it or you dump hyaluronidase into it without thinking, you can spread an infection or light up the inflammation and make it dramatically worse. So the very first thing you do on that call is figure out which lump you're dealing with by when it showed up and whether it's inflamed. Once you know it's a delayed inflammatory nodule, you take a specific history because the trigger tells you a lot. You ask, have you been sick recently? Maybe you got a cold, a flu, a sinus infection. Have you had any dental work, cleaning, root canal, any vaccinations, any recent injury to the area? Because these nodules are often set off by an immune trigger somewhere else in the body. The patient almost never connects those dots, so you connect them for her. Now the granular part, what's actually going on and what do you do about it? In order. A delayed nodule is usually one of three things, and they can overlap, okay? It could be a low-grade biofilm, a quiet colony of bacteria that's been sitting on the filler since the day you injected and just got provoked, okay? That could happen. It can be a delayed type of hypersensitivity reaction where the immune system decides all of a sudden it doesn't like the product. Or it could be a true granuloma, a foreign body reaction, and an infection can sit on top of any one of those three things. Here's the order of operations, and the order matters as much as it did with the aging lip. The first thing, if you suspect any infection or biofilm at all, antibiotics lead the course. Not steroids, not the scalpel. The classic published approach for a suspected biofilm is dual antibiotics. Typically a macrolide like clarithromycin combined with a fluoroquinolone like ciprofloxacin. So, and you do those two things for, usually 7 to 10 days, maybe up to 2 weeks. And this part is critical. When you suspect biofilm, you do not incise and drain it. No, that's a bad idea. And you definitely do not inject steroid into it first. Steroid lowers the immune system response. We don't want that. If you cut it or open it or steroid it, it's going to dismantle the bacteria and make the whole thing worse. Bacteria are going to spread, you're going to get an abscess, the list goes on and on. Now, once she's covered with antibiotics, then hyaluronidase becomes your friend because the filler is the scaffold that the biofilm is living on. So you take away the HA after their antibiotics. You dissolve, but you dissolve under antibiotic cover, not before. That way you're not going to spread that infection to other parts of the body. The third thing you do for inflammatory granulomas is once infection is controlled, that is where intralesional corticosteroids like triamcinolone comes in. And for a stubborn true granuloma, the literature supports adding low-dose 5-fluorouracil, say that 5 times fast, to the steroid. Oral steroids for a severe flare, and surgical excision is the absolute last resort for the rare nodule that fills everything else. The exact drug doses live in your cheat sheet, and they should always run through your medical director or on your own prescribing protocols. But the framework you carry into that phone call is this. Identify it as a delayed and inflammatory. Take the trigger history. Cover with antibiotics before you steroid or dissolve if infection's on the table. Then use hyaluronidase to pull out the scaffold, and then that will settle the inflammation. Order, not panic. One more actionable piece, and it's a product selection one. Not all fillers carry the same risk for this. The Vicross technology fillers, the ones a lot of us reach for in lips because they're smooth and they last, they have a higher documented rate of these delayed nodules than some other products. That doesn't mean don't use them. It means know it, weigh it, and add it to your product choice for a given patient, and counsel the patient accordingly. So let me test you with two different scenarios, 2 different calls. Okay, we're going to talk about call 1. Patient's 10 days out, a firm small lump or bump. It's not red, it's not tender, just popped up. And she's calling you about it. Okay, that's scenario number 1. Call number 2, 5 months out, a tender warm lump that came up the week after she fought off a bad sinus infection. Now take a second and tell me how each one is different and what you should do. All right. Probably already figured this out. It's not really rocket science here since we've been talking about this, but call 1 is your non-inflammatory settling lump. How do you fix it? Massage it or touch a little bit of hyaluronidase in it. What I typically do is I'll have them really push hard on it. It'll pop that little bubble and it'll integrate nicely into the tissue. If they can't do it, have them come in, get some gel, like some arnica gel on your finger, just really work that out and you're gonna massage that away. Okay, so that's the first call. What's call number 2? That's the delayed inflammatory nodule. It has a clear infectious trigger. You got that history. What do? Antibiotics first, then dissolve under the cover of the antibiotics. then settle down the inflammation either with steroids or hyaluronidase to get rid of that lump. All right. So it's the same lump to a beginner. A beginner hears a lump, they might think that they're all granulomas, but that's not necessarily true. Completely different protocols. Now let's close with the complication you're going to see more often than any other. And the one you have the most control over, if I'm being frank, migration, the filler mustache. The patient comes back and there's a ridge of fullness sitting above the vermilion border where it has no business residing, okay? That lip outline that you designed, it's gone soft, and she's read online that her filler migrated. Like it packed a bag and went on a trip. And that's exactly what it did. The large majority of what we call migration is not the product wandering off on its own. It is the predictable result of how it was placed and how much. And that is the great news, because it means it's mostly preventable by you, the injector, with a few specific rules. This module are those rules. What are they? Rule number 1 is the entry vector, where you enter and which way you aim physically decides where the product ends up. When you enter above the vermilion border and drive product downward and across into the lip, you are pushing it toward and over that border. And that is a setup for a super vermilion ridge. The anatomy studies on this are clear that injecting from above the vermilion border and pointing down has a higher tendency to migrate. So your default should be to enter so that you're depositing right at or below that vermilion border and never pressing product up and over the edge. Treat the vermilion border like a wall you stay behind, not a line you push across. All right, so that's rule number 1. Rule number 2 is the plane and the pressure. The lip is a high pressure, constantly moving environment. The orbicularis oris is contracting all day long, and hyaluronic acid is hydrophilic. It pulls in water and swells after you place it. So 2 things drive creep. So placing too superficially right at the border where there's nothing to contain the product and putting in too much volume in one session, so the tissue pressure has nowhere to go but out and over the edge, what does that do? It leads you straight into rule 3. Rule 3 is you cap how much you place per visit and you build over multiple sessions instead of chasing the final result in one sitting. And here's where the bucket comes back. You fill the bucket, it draws back down, she comes back before it's empty, and you top it off. And you do that for years without ever emptying it. That stacked, never reset product is what slowly creeps up and over that vermilion border. So the rule is every couple of years, you stop topping off, completely dissolve in 2 or 3 hyaluronidase sessions, and you start clean. I've been doing that for years in my practice, and I tell my patients when they first get lip filler with me, part of my protocol is you will be coming in every 2 to 3 years, and when I think you've had too much, you have to let me resolve the issue by dissolving the filler and getting you back to where you came in today. And that will keep them looking natural for years to come. So learn to tell those 3 things apart. True migration, product sitting above the border where you never placed it with a blurred outline, simple overfill where the lip is just too big, but the border is still crisp, and the normal little super vermilion bleb that integrates and disappears on its own in a couple of weeks. A beginner injector panics and dissolves all 3. You only chase the first one. Do not dissolve a lip that just needed 2 more weeks to settle. So let's wrap it up and put a bow on this whole course. This was not a how to inject a lip course. You already have done that. This was the layer above it. You walked in able to fill a lip. You walk out with 3 protocols you can run in your next clinic day. For the aging lip, you release before you fill. You restore structure under a sealing, and you know the 3 findings that mean refer instead of inject. For the delayed nodule, you've got an actual algorithm. Identify it as inflammatory, take the trigger history, antibiotics before steroids or dissolving when the infection's on the table, then you pull the scaffold and settle it down. And for migration, you've got the entry rules, the per session sealing, and the reset cadence that stop it before it even starts. That is the difference between somebody who just injects lips and another injector who has patients driving across the state just to come see them. So take these 3 into your very next consultation and put them to work. Now, go seize the day.